My name is Dr. Philippa Kadama. I'm presenting the poster on behalf of the authors. The poster is entitled, Why Are They Diagnosed So Late? Understanding the circumstances preceding diagnosis amongst patients with KS identified by rapid case ascertainment in East Africa. By way of background, we know that approximately 80 to 90% of KS patients in sub-Saharan Africa are diagnosed late when the available treatment for KS is no longer effective. We have very little understanding of why the patients are coming in late, but we've seen reports from Uganda that have shown that healthcare system delays are contributing greatly to this late diagnosis, and a study from Zimbabwe that showed that training primary care physicians in early detection of KS had no effect on decreasing the prevalence of late-stage diagnosis of KS. So the authors set out to describe among HIV-infected patients ultimately diagnosed with KS, their care-seeking experiences from initial cognizance of suspicious lesions to their obtaining a KS diagnosis. The study was a cross-sectional study, and it was done amongst HIV-infected adults above the age of 18 who had been newly diagnosed with KS. The patients were enrolled at 3 sites, 1 in Kenya and 2 in Uganda, between June 2016 and May 2019. Measurements were taken using a structured questionnaire informed by the model of pathways to treatment. We looked at data for 286 participants who are HIV-infected adults newly diagnosed with KS, and 96% of these completed the pathway to diagnosis questionnaire. Of the participants we looked at, their median age was 35 years, 31% of them were female, almost 50% had no education or primary level education. The monthly income was approximately 440,000 Uganda shillings, which is about $120. 83% of the participants at time of enrollment were at SCTG T1 stage. In terms of initial cognizance of the lesions, the first person to notice the lesions was reported as a participant themselves in 97.5% of the cases. Only 1% of the patients reported that the person who first saw the lesions was someone in the healthcare system. In terms of the anatomical sites where the lesions were first noticed, 71% of them reported the lesions first being noticed in the lower extremities. 12% reported lesions first being seen in the upper extremities. Other anatomical sites where lesions were first seen included the head and neck, oral cavity, chest and abdomen, and the back. In terms of the participant experience at first consultation, the median time from first seeing the lesion to seeking care was 4.3 weeks. The first person consulted for help was a biomedical provider in 91% of the cases. Other providers consulted included a friend, religious or village leader, traditional health practitioner, community health workers. In 29% of the participants, they reported obtaining a KS diagnosis at their first consultation. In terms of the opinion of the first person consulted, 38% of the participants reported being given an opinion of suspected KS at the time of their consultation, and only 5% reported being told that it was a form of a cancer. What did the participants do after their consultation? 28% of them reported using antibiotics, steroids, analgesics, diuretics, and other unspecified treatments, and almost 10% of them reported consulting a traditional health practitioner or using traditional medicine or praying after the first consultation. So in conclusion, we see that in a community-based representative sample of HIV-infected adults newly diagnosed with KS in East Africa, we observed delays in KS diagnosis attributable to both patients failing to promptly present and healthcare providers failing to make the diagnosis of KS. The implications of these are that interventions to promote early KS diagnosis should target both the public and the healthcare system. An increasing awareness of KS in the public would not only hasten presentation for care, but might also influence better healthcare management systems. Thank you.